Just going on, actually. My kids have been sick.
All right, good morning, everyone. We're going to get started. Welcome to the Wilson Center. I'm Sarah Barnes, and I lead the Maternal Health Initiative here at the Wilson Center. For those of you who are not familiar with the center, we are a living memorial to President Woodrow Wilson, who remains the only president to have received his PhD. And the Wilson Center is a nonpartisan, non-advocacy policy forum. And the Maternal Health Initiative is dedicated to navigating gender-based health issues with a particular focus on maternal and reproductive health. Excuse my voice, I'm losing it slightly. This is our 11th year of partnership with UNFPA on our Advancing Dialogue on Maternal Health series. And this year, in honor of the World Health Organization's declaration of 2020 as the International Year of the Nurse and the Midwife, the Wilson Center and UNFPA are partnering on a series of public and private events focused around midwifery. Can I get a show of hands of how many people in the room are midwives? Nice. Do we have any nurses in the room? Anyone else in the workforce? OBGYNs, anything? There we go. I wanted to get you in there, Will. So today's event, The Importance of Midwives in Achieving Universal Health Coverage, is the first public event in our series, and we're delighted to have such an amazing panel here with us today. Thank you so much for traveling far and wide to be with us. Currently, there are 22 million nurses and 2 million midwives globally who are responsible for delivering more than 80% of healthcare in low-resource settings and account for more than half of the world's healthcare workforce. The world, however, requires more than 9 million additional nurses and midwives to achieve the ambitious target of universal health coverage for all by 2030, set in the Sustainable Development Goals. Today we'll be led in conversation by Annika Knudsen, Chief of the Sexual and Reproductive Health Branch at UNFPA. A special thank you to Annika and Gita Lal and Sarah Barziv from UNFPA, who are my partners in organizing this event and for the last 11 years of wonderful partnership, as well as Dikshita Ramanarayanan, who is here, my program intern, and Amanda King, our program staff from Maternal Health Initiative, for all of your hard work on this event. So before I hand things over to Annika, a little housekeeping. Bios are available outside of the room, as well as many printed publications from our .mom blog on midwifery. At the end of the event, we will have a Q&A session. So we ask you to please start thinking about your questions as the discussion is happening, and to please make them actual questions. Yes, let that sink in. Questions, yes, thank you.
Not declarations.
Yes, not dissertations. Yes, thank you. And for those watching online, and we have a huge number of people viewing us online today, you can send your questions on Twitter to @Wilson_MHI, and I will get those to Annika as they come in. Okay, so I will hand things over, and please join me in welcoming our staff and Annika, or our speakers, and Annika to the stage.
Thank you, and let me also say a warm welcome to you from UNFPA to this celebration of the Year of the Nurse and the Midwife. I think this is long overdue. I think that it should not just be the celebration of a year, it's the celebration of the decade of action, and let's make that happen so that it's not just a one-year event. This is the starting point for a series of very important accelerating efforts to really increase the knowledge about what midwifery is, what midwives do, what nurses do, and how we complement each other together with the OBGYN. I can just let you know that we had sort of a little brainstorming session here yesterday at the Wilson Center where we discussed this, among other things, the need for the team to work. And I'm sure that we will work closely together, and I'm sure we will touch upon that today as well. I will just want to say that I want to introduce my panelists here, and as Sarah said, the bios are out there. I won't go deep into all of your amazing careers, but I want you to know that we have 3 women here that have committed their professional life to what women, girls, and families want and need in different ways. And that really is very, very commendable. So I want to give an extra hand. We have Elena Ateva. She's with the White Ribbon Alliance, and there she's an advocacy manager, and she will tell you, when we get to the panel discussion, she will tell you a little bit more, I think, about what White Ribbon Alliance does, but also about the gender part of what we're going to discuss. Next to her, we have Franca Cadet. She's the president of the International Confederation of Midwives, also an amazing advocate for women, for girls, for families, and for, not only health interventions, not only survival. And that's what we're going to talk about. It's not just about survival. It's about the health, it's about quality, it's about all of that. And then, last but not least, a countrywoman of mine, Marie Klingberg Alvin, who is a midwife and a professor in sexual and reproductive global health, I think it's called, and currently with the University of Massachusetts. Michigan. Sorry, I don't know my American geography. Sorry, Americans. What we'll do today is we'll have a panel discussion first on the role of midwives in universal health coverage. And I will start off with talking a little bit more generally about, Sarah did a good job, I think, in starting off what is universal health coverage and why is it on the top of the agenda now again. And then we will hear from Elena, Franca, and Marie about their perspectives, but then it's really important that this becomes a dynamic discussion with all of you, because I think also the reflections on what they have said. So I think form your questions around that, and if you have, towards the end, we will also allow for more comments. But it's really important that we get this to be a dynamic discussion, I think. I will come to this image that Sarah has helped me put up here, but I just want first to start to say, we are in the decade of action, as I said. And with that, we are moving very fast to 2030 and to the deadline for the Sustainable Development Goals. And within that, there was a commitment to universal health coverage. And that includes financial risk protection, access to high quality essential healthcare services, and access to high quality and affordable medicines and vaccines. To reaffirm this, in 2019, in the United Nations General Assembly, it was reiterated in the high-level declaration on universal health coverage that we recommit to that agenda. But it also, and we were really happy about that, because that was not, you couldn't take for granted that SRHR should be really still a part of that. We wanted that very much, and we know that without SRHR in universal health coverage, there will be no universal health coverage. So we were happy to see that it was re-emphasized with the SDG language, with the sort of aligning with the ICPD agenda again. And just to say that, again, that UHC is really impossible to achieve without also addressing the needs of women, girls, and families when it comes to the sexual reproductive health and rights needs. But similarly, universal SRHR cannot be achieved unless countries embark on the pathway to universal health coverage. So it's a dual process that really needs to happen. And what we need to have, I think, and that's why we put this up and why we at the Nairobi summit as UNFPA led a group to come up with a description of what SRHR is and what it looks like as an essential element of UHC. We will provide you the link to this document so that you can have a look yourselves. It builds on the SRHR Commission that Guttmacher Lancet published in 2018, and it talks about the essential package. Of course, WHO is in the lead of putting the UHC total package out there with the costing, with the health workforce needs, etc. But we felt that it was important to say that we need a more comprehensive approach. If we're going to end preventable maternal deaths, if we're going to meet the unmet need for family planning, if we're going to end gender-based violence, we need a comprehensive approach. You can't just cherry pick and do what you think is the most comfortable areas to address. So I'll not go through all of this, but just to give you a view of, this is really, the outer wheel is a turning thing, and it's really trying to visualize the life course approach, where quality of care, equity and access, quality of care, and accountability are the three main principles. So here we can see that antenatal, childbirth, and postnatal care is, of course, one of the pieces that we think of midwives in. But all the other pieces are actually spheres of work that midwives can work in. And just to reiterate something I said, and then I'll hand over to the panel. We know that midwives can sort of provide maybe 87% of those interventions and services, but only if they're, legislated, regulated, provided the enabling environment to be able to work through the whole scope of that practice. So, having said that, and having the picture there, and there may be other photos that will now come, but we can come back to this when we have the open discussion as well. I would like now to turn to you, Elena, and just before maybe we discuss the role of midwives, I would like to ask you what you see as the biggest barriers for women and girls in achieving universal health coverage. What is it that you see, and what is it that White Ribbon Alliance is really trying to work on in this area?
Thank you so much, and thank you for welcoming us here so warmly today. This is a topic that's very close to my heart. Thank you. I'd like to start as the only not midwife here on the panel, and say that I want to speak from the perspective of a woman, the perspective of a human rights attorney, which I am, and the perspective of an advocate. So all of those identities come into one. I want to talk about the right to health, because universal health coverage is essentially about the right to health. And this is a right that all countries have agreed to respect, protect, and fulfill. And these are very substantial obligations. And we, like Annika already mentioned, we cannot really talk about universal health coverage without talking about sexual and reproductive health and rights. We cannot really focus, and we can't say it's universal if we don't include SRHR into the discussion. Unfortunately, what we have witnessed in the past years around the world is a really serious backlash, where we're now trying to defend basic, fundamental human rights of women and girls everywhere, instead of really focusing on pushing the agenda forward and progressing. We're really, every day we're step by step defending what is left. So we have to be very honest about that, and we have to have honest discussions around that. Can we really achieve universal health coverage? Can we achieve the SDG agenda if we cannot be pushing forward, if we can't have a progressive agenda, if we keep fighting to hold on to the little that is left? And I don't think so. And 10 years is not very long. So we have to be really frank about that. For me also, the conversation around universal health coverage has to be a conversation around quality. And quality of care, not just the way health systems define quality of care, but the way women define quality of care, the way women experience quality of care and the way they perceive it. And that's different. It might be the best intention of health providers to provide quality of care, but they're really not in the shoes of girls and women. They're not the ones receiving services. So it's really important to hear from women. And that's what we at the White Ribbon Alliance did in the past couple of years. We asked women around the world what they want for their own health, for their own reproductive and maternal health care. We heard from 1.2 million women from around the world, and by far, the number one response was respect and dignity. And how do we measure that in the healthcare facility? Do we have a way to really track that and to make sure that we're providing that service in a respectful and a dignified manner? And that differs also from community to community. What is respectful to me might be different, based on where I'm from, the way I look, everything. What we heard, the words, and I just want to share some of the words that we heard from women because they're so poignant and they strike you right in the heart. We heard, don't make me feel small. No insults. Listen to me. Make me feel welcome. There was even one that I'm not going to forget because we laughed so much when we heard it, but I agree 100%, was treat me like a queen. And I just love that because this should be, it's not just about not doing harm, but it is really about promoting health and well-being for women, for families, for communities, and that's how we should be treating everybody. We need strong women-centered accountability mechanisms, and that's another area of concern that we are working on in countries around the world to strengthen. We need accountability mechanisms that are informed by women, where women can continuously provide feedback, where that feedback is actually taken, and changes based on that feedback are made. And this is also an integral part of universal health coverage. So equity, quality, accountability, human rights, central to universal health coverage. And of course, SRHR. Without SRHR, we cannot have universal coverage. But the main element, the main discussion around universal health coverage has to be around the human resources that we have or currently don't have, because this is such a huge gap. And I'm really worried about that. Sarah mentioned was it 9 million? Yeah, nurses and midwives. And WHO says 11 million additional health workers in general by 2030. White Ribbon Alliance has done specific work in Malawi, for example, to identify how many more midwives are needed. And we discovered that 20,000 more just to get to minimum WHO standards. That's just the basics, the very minimum. And again, I want to speak as a woman who has used midwifery services and to tell you a little bit more about what midwives provide and why they're so critical for our health and to achieve universal health coverage. My esteemed colleagues here will speak more about the specific contributions of midwives, but I want to speak from the perspective of the user of the system. Midwives are with women, and that's literally. They're the ones that will take care of you when you just had a miscarriage, and they'll advise you on how to take care of your newborn. Or they'll sit with you during childbirth and just sit and give you space. They provide care throughout the life course. So they can show you when you're young how to use contraceptives or advise you on an STI. And they will help you manage the effects of menopause when you get older and anything in between. The work that they do is really about preventing complications. And I love that because as much as I appreciate the fact that I did have high quality NICU care for my newborn, I really appreciate the fact that with my second that was born with a midwife, I didn't have to even access NICU. We also rely on midwives to provide continuity of care. Midwives are usually within the community. They might share the same ethnic and religious and cultural and language background as the community. And they really can connect with women, they connect with the families, and they can establish that close relationship of care and trust. That's really critical. Midwives protect rights. They're the ones that you usually can access when you're a victim or a survivor of domestic violence or sexual assault. They might be the only ones, actually, that you can access. So they would be the only point of contact we have with somebody else. And they're great in times of crisis. They're usually the last ones left, in an emergency, the last ones left to care for women, to care for the communities. I want us to understand the need for the health workforce, and especially for midwives, also in the reality that universal health coverage has to be seen in the broader context of social determinants for health, and what else is needed outside of the health system. So the task that we have in front of us today to discuss how we overcome the barriers and how we push past the status quo is an immense one. So I hope we continue the discussion. Thank you.
Thank you. And that was really a lot to make us start think about both the role of women and focusing on that, but also the role of midwives. So I'm turning to you, Franca, now, and asking you to talk a little bit about how you see that we can optimize the contribution of midwives to achieve UHC and other things that you see are maybe lacking in that perception and understanding of what UHC is.
Great, thanks very much. And thank you, Elena, because I think it is really right to start with women first. The word midwife in Anglo-Saxon actually means with woman, midwif, with woman. And I think it's a beautiful word. But of course, the name for a midwife in every culture is a different name. The International Confederation of Midwives is like an umbrella organization of 142 associations worldwide. We are about 1 million midwives. And confederation sounds so like a big kind of static house. I'm really seeing ICM become a movement. I think we are a movement of midwives, and we need to be a movement of midwives. And midwives are mainly women. There are some male midwives, but mainly we're women. And so we have many of the similar issues that the women that we care for have as well. And I think that's something interesting to talk about. One of the things I was thinking about, but we can talk about it later, is the whole issue of compassion fatigue. Of course, if a whole workforce is treated badly, compassion fatigue is a really big issue. And as midwives, we need to look at ourselves, but also others need to support us. But I think midwives worldwide have a very different scope of practice. That's also something that is quite an issue. As ICM, we do have standards, and our standards are visionary, and we need to have standards because the reason why I think worldwide how midwives are looked upon is so different is that we've had many quick fixes. And many people seem to think that as midwives, that you can kind of have all the different tasks as midwives divided under different types of people. But actually a midwife is a whole, is one person who does the whole continuity of care for the woman. And you can't split that up into different people. It's like a knowledge base, it's like it's an education, it's a skill, and it's also humility, all in one. That is what a midwife is. And I do think that the global quick fixes, patriarchal models do not really work that well for midwives. And so I don't think we come to our potential as well in patriarchal models. And part of that patriarchal model is the conflation of midwifery with nursing. I think that midwives and nurses as a big workforce can support each other much better when we both know each other's identity. When you have your own identity, you can support each other. But I think within the patriarchal system, women's work is women's work. You would never confuse a pediatrician with a cardiologist. But nurses and midwives, well, it's nurses and midwives. And I think we need to be really careful with each other and support each other as nurses and midwives. And I think this year, the year of the midwife and the nurse and the midwife, I think is a really good sign of that. And for us as ICM, it is the first year in the decade of midwifery. And it really is the first year in the decade of midwifery. And there's so much excitement around. The whole issue you were talking about quality, I do think attaining UHC can also be done by looking at quality. It's not only about access, it is about quality access. And we know that if you actually, midwives have such amazing skills that if it were a medicine, if midwifery were a medicine, it would have actually been used a long time ago. We know that if you have continuity of care by a midwife, it actually reduces preterm birth by 24%. Well, if any of you knew a medicine that could do that, it would be implemented tomorrow. If the pharmaceuticals heard about this, it would be implemented tomorrow. But somehow midwifery isn't, and that is because it's more complex. I think the investment in midwives sounds easy, but the investment in midwives means that we have to all work together, because midwifery is a system change. It's a complex thing that sits within a system. You have to invest in the education of midwives, the regulation of midwives. They have to be legally protected. They have to work within a team where you work with other healthcare professionals, and especially the obstetricians and also the pediatricians. But I think especially the obstetricians and midwives need to work hand in hand in understanding each other deeply and understanding each other's skill deeply. I think of all the healthcare professionals, when you talk about healthcare professionals, midwives are really healthcare professionals. Many of the other healthcare professionals stop us from being ill. Midwives actually help us to stay healthy and, of course, take care of women who are not healthy and at times refer the care to someone else. As ICM, we really see that every woman in the world, for her sexual reproductive health and rights, needs a midwife, and some need a doctor too. And once she's referred to a doctor, that midwife is still needed there as well. As well, what we see is that in certain countries where the maternal mortality is so high, we're told, well, you can't have this vision of having this continuity of care of a midwife the way you talk about as ICM, using the ICM definition in that country, because, you know, they can't manage that yet. But actually, the women in those countries need that more than anyone else. Those women need more high-quality care than anyone else. And we have to be visionary. We know the return on investment in midwives is 16-fold, but it is an investment. And we're all born. Every single one of us is born. And so this is not for midwives to do, this is for all of us to do. And I can see this happening. I mean, that's why we're sitting here together. I can actually see it happening, that more people are realizing that it's so great as a midwife. I don't, at meetings, need to say midwife, midwife any longer. I don't. Because other people are speaking midwives nowadays. And so we can really talk about the true implementation of midwives. And with what's happening globally, with, as you say, the sexual reproductive health and rights of women, we really have to hang on. At this point of time, midwives who do the full scope of practice, from abortion services to contraceptive care, all the way through before pregnancy, adolescents, that adolescents can come to midwives to make sure that they don't get pregnant. Women have the right to make sure that they can get pregnant when they want to get pregnant, give birth where they want to give birth, and be treated well. And not only stay alive, but live a good life.
Thank you. And I'm burning here to ask you follow-up questions, but I will wait. I will wait, because now it's Marie's turn. And you know, you have a broad experience of exactly what Franca was talking about now, how midwives can be sort of really key implementers also in other areas on the broader SRHR. And maybe if you could say something about that more in depth, and also talk a little bit about your own country, Sweden, and what role has midwives played there in achieving universal health coverage?
Yes, thank you very much. Thank you for inviting me, and thank you for providing the base here, going into a specific country's example. And so the increasing midwifery competence and access to midwives during, after, before, during, after childbirth, as well as in contraceptive counseling, abortion care, as such, has been a centerpiece in Sweden since many years. And the Swedish midwife work independently and autonomously, as according to ICM standards, and provide this care from a life cycle perspective. And I think the figure that was showed just recently, the comprehensive approach to sexual reproductive health and rights, most of the components in this figure actually correspond to the scope of practice of the Swedish midwife. She is an actor, not always being the main operative provider, but she does support sex education for schools, for example. And so all this is reflected. And the fact that essential parts are included, not only maternal health care, antenatal health care checkups, the delivery, aftercare. She also meet with women and their partners, in case there is one, in counseling for unplanned pregnancies, contraceptive counseling, and nowadays an estimated 80% of the induced abortions in Sweden are early and managed by midwives. They can be certified and trained to conduct medical abortion. And this history and this development has been taking place during a long time. And I have this book with me to illustrate it. It took 300 years. This book is available on the website of the Swedish Midwifery Association. So I then want to highlight the fact that all this positive change and where we are today is because of different efforts in society and the development, of course. However, I want to highlight a few important aspects, and then the core, I would say, is that we have educated midwives since 309 years now. 300 years. And we have had our own midwifery association since 134 years. So we have this long track record of supporting the midwifery profession from the highest level in society. We have governance, we have had policy framework, we have had supporting laws, and it has been implemented in action plans, in strategies, nationally, but we have also promoted this globally in different sort of actions through our UN Foreign Affairs and the policy aid. And this has, of course, created both opportunities and this positive change. What I would like to highlight also is the core of having high-quality midwifery education. And in Sweden, we have 6,700 members now, or midwives, and of these, close to 180 have a PhD. So, and we have tons of masters also, because our education has been on advanced level for some time now. And all these midwives are in the clinical sites, working to improve the quality of care constantly, together with obstetrician gynecologists. And one of the core is also this interprofessional collaboration, the mutual respect for each other, and clear roles and responsibilities. And I think the Lancet series now, who was published 2014, could give us guidance in this task sharing between the midwife and when you need obstetrician gynecologist. I think I stay there, and then we can have an...
Thank you so much. And I know also your partner panelists, I think, are burning to reflect on this. But I just wanted to follow up with you, Elena, because I think what you said, you touched upon it, but and what is inherent in the word universal is that it is for all women, right? So we're struggling really in achieving the SDGs with leaving no one behind. And it is important, it is an inherent value, but it's also become a buzzword. So from your perspective, what is really needed now to make this really universal? You talked about it some, but how can we reach the women who are living with disabilities, the women who are indigenous, the women that are of another gender identity or a sexual orientation, etc.?
Sure. Well, I think the first thing we need to do, and we need to keep doing continuously, is to ask them what they really need and want, because we will get one answer from a woman living with a disability, we'll get another yet from an indigenous woman. We, in general, have not really regarded our indigenous women with a lot of respect at all. And in terms of how services are provided, we've asked them to conform to what's available. We haven't really asked them how they want services to be provided in their communities by people who are from the community. And in terms of also taking into account other beliefs outside of the healthcare system, health is not just about the healthcare system. We have not considered beliefs and customs and traditions and have actually actively disregarded them. I just read an article yesterday in a Maori publication that was talking about, the title was really, WHO finally realizes an old Maori practice about not getting the cord right away makes sense. So this, there are practices that have existed for hundreds of years that science is finally coming to terms with, but we haven't really, and we still are not actively reaching out and asking those communities what they need. It's the same is true for people from the LGBTQI communities. We really cannot be making policies for them without being in their shoes and knowing what they might need and what they're facing every day. So that's the first, and like I said, a continuous process of keeping and asking if what we are offering, if it's okay, and honestly, not making policies for anyone else. We cannot determine policies for somebody else. We need people to be part of those processes, identifying the issues, identifying the solutions to them, designing policies, being part of the monitoring process to ensure that what is proposed and works, and being really in the leadership of that. And this is something we're not seeing yet. We don't see that diversity in even in panels like this one. So we need to call this out every time we see it. We need the diversity to be everywhere at every level of decision making. And that's when we really meet the needs of those who are most marginalized in our societies.
Thank you. Turning to you, Franca, and a little bit the same question then. How do you see midwives being well placed to actually do that reach out, and what do they need to be able to do so? Because we can also not put all the responsibility on the shoulders of midwives to solve all the problems of the UHC, right?
Yeah, I do agree that the last comment, I think we really need to be careful to think, midwives, that's the answer. Because midwives are part of a system. That's what midwifery is. So I think that we do need to realize that it's part of a whole system. I think that what you're saying about, kind of the representation of the community here, you can see what happens. And I think within midwifery too, people from certain communities need to also be trained as midwives. You do see that working really well. In those communities, you see it, for example, amongst the Maori. There's quite a few Maori midwives who have the combination of their medical training and then the indigenous knowledge together. And I do think in general, you need to have midwives trained from the community. We need to have equitable representation of our community within midwives. And I also think that midwives need to be present in the change. Interestingly, I just came yesterday, I was at the Chief Midwives meeting in the UK, where you now have a midwife, like a medical officer to the Minister of Health. You now have a midwife that advises the Minister of Health about midwifery. And I think in this way too, you need to have midwives not so much doing the work. I think a lot of people are happy for midwives to do the work. No, not only doing the work, midwives there at the decision table, at the ministry, with politicians, and then having midwives who speak from the community, because they can be part of the community.
So a follow-up short to that, because you are, of course, the person in the world having, the oversight of actually what midwives need and want. So we discussed yesterday that getting midwives at the decision table also needs a process. It's not just putting them there as a token. So what do you see that, people in this room as decision makers, as programmers, what do we need to invest in to actually be able to enable them to be part of that decision-making process? I think Marie spoke about the higher education, but there are other things, I think, too.
I do think the higher education is one. I think that certainly our relationship with obstetricians at times come from the fact that they have a very, very long education, and somehow their way that they're able to approach certain things and approach research might be different from midwives, and it really helps having midwives up to the same level. At the same time, I do also think it has to do with the fact that we have to listen. We say midwives have to be empowered. But if as a midwife, you're able to be with a woman and do really difficult things that have to do with life and death, midwives have transferable leadership skills. We have amazing leadership skills. Midwives don't need to be empowered. Midwives are very, very powerful. midwives simply need to be listened to. So I think what we need to do is to dare to listen. And I find as a midwife quite often people come to me and say, well, fine, Franca, what you say, but say it in a different way. Then I think, well, I thought you were going to listen. So this is how I'm saying it. And you might not like the way I'm saying it, but generally when we're hearing things that make us feel uncomfortable, we're probably on the right road. Not always, but so I do think that listening to what midwives say, even if we think, well, what is this midwife saying? I think if we keep on saying, oh, midwives have to come to a certain standard, and then we can start listening, we're going the wrong way. Let's start listening to what midwives say, and also support each other to respect each other, and to have the right education to be able to say the right things and be positive and constructive.
Thank you. Marie, turning to you and maybe tweaking the question a little bit, because you spoke about the many PhDs, the masters in Sweden. What has it taken in terms of changing the academic way of looking at midwifery, and what was that journey like? Because it sounds so easy and it's all there and that's how you should do it. I think it's important to hear a little bit about that.
So nursing and midwifery became academic education programs in the beginning of the 90s, and I think it was also in the beginning of the 90s we had our first professor in caring sciences, and followed by professors then specifically in the subject sexual reproductive health and rights. We have been fighting for that. I was director of one of the midwifery education programs during this time, and we had to fight to have this as our own subject because it corresponded to being a registered midwife and our scope of practice, which lies within sexual reproductive health and rights. So that is a journey, and it took time. We now have these 13 midwifery education programs in Sweden, and of course it is handleable to support each other, to create an environment for quality improvement in our education programs and so forth. But and our Midwifery Association is crucial in this process, supporting and facilitating this. But I think what is also important is to have strong academic environments where you also have research. It's not only about educating the clinical skills, it's also to give them the ability to reflect, to read new science, to be part of developing new standard guidelines in the clinic, and to be vocal and to take lead for your own profession. I think actually this is one of the most crucial to have midwives who actually take the lead, to support them. There is a lot of capacity, skills, but leadership capabilities, I mean, you need to promote that. And I think that is one of the crucial things maybe for ICM to take up, to support these local midwifery associations, to have their ambassadors. And this is, I know it's happening, but we have a decade now. And to close the gender gap, I mean, so that is the core here in all our discussions, right? To close the gender gap, you need to have gender intentional governments to start with. And you also need to have government who give status to sexual reproductive health and rights. And the Nairobi Summit provides a wonderful foundation now, I think.
Thank you. Just a reflection from my side, because I think when we talk about education, when we talk about decision-making skills, when we talk about, enabling midwives to be part of all of those processes, there are many things in different countries that really, Sweden has had, because in the basic education system, you value critical thinking. But in most education systems today in low-income countries, that is not something that is, even if it's valued, it's not something that is possible to really teach, because you have classes that are 70 to 100 students in one group. So you sort of have to memorize. So I think there are things that we need to do in working cross-sectorally as well and beyond the health system, beyond the health workforce, to improve the foundation for adapting that critical skill, I think. Now, we'll soon open for the more for the rest of the participants to engage in the discussion. But I actually wanted to go back to you once more, Marie, because I think it's not fair to say, because it's a good system that we have in Sweden, and I'm, as you now hear, I am Swedish. But we still do not have the salaries midwives deserve. We still do not have the work environment that midwives need. So going back to what Elena started with, this is a gender issue. How do you see that what do we need to do to change this? Because this is just outrageous.
Yeah. I mean, that is also, I mean, we share this challenge. Sweden share this challenge with all other countries. And it's a very fresh and current debate at home. I mean, in media, we have women picturing their needs, how they have been disrespected, and all sorts of terrible stories, actually. Midwives are frustrated. Midwives don't want to work as midwives longer. We have a new young generation of midwives coming now, and they question, why should I have this sort of, working environment? We have our Midwifery Association. We have now joined, so we have our own union. And that means that the midwives will be at the table when you negotiate salaries and work environment, for example. So that was one step the Swedish Midwifery Association took last year. We are also trying to push for having our own chief midwife officer taking place in UK and elsewhere now.
Chile?
Yeah, so there could also be, I mean, that would be necessary for the quality of care in Sweden as such, because our system now we depend a lot on the politicians' decisions, and they don't listen to the professions. They don't listen to the physicians or the midwives or the nurses. So I'm a bit harsh now, but this is actually the situation we have now.
We want honest discussion here.
And we have terrible consequences in parts of our country because of organizational decisions, which is not evidence-based.
Yeah. So Franca, from your side, leading the associations, how can others help? I'm after a little bit. How can we partner to change this situation?
Well, I certainly think that doing something like having a chief midwife, I think having a midwife kind of at the top of a Ministry of Health or the Ministry of Gender. We don't have to always think health. Gender at times leans much closer to what we're talking about. I think is very, very useful, and supporting each other to do that. So actually we will be trying to get all the countries that are working on chief midwives to work together to try to see how they've managed, because every country, they need to kind of find another back door or front door to be able to get this, to push this forward, because every country is different. But I think that is one way in which you can do it. I think all of us need to realize that when you work with midwives in a country, always involve the Midwifery Association. Never go around the Midwifery Association in a country, because those are the ones that speak for midwives in that country. So respect that. I think that helps. Interesting, did you know that the Canadian midwives have just won a case for pay equity? Yeah, they've had a big court case for pay equity. And the pay equity issues for both midwives and nurses and all the women healthcare professionals, it is a huge issue, because I think we still have this idea of the women's workforce being the carers. They're the home carers, and the main people that earn money is still men. And so I do think that realizing this and working more through gender, with the gender lens, I think will really help this. But supporting each other, seeing where it works well, and being conscious. These kinds of meetings, becoming conscious, I think, step by step, we're getting there.
And in many countries, midwives have to wait 3, 4, 5 months to get their salaries, and they still
sometimes
continue
don't get paid
to work.
at all.
And so I think the whole idea of informal, formal work, it's blurred here. But Elena, yes, to turn to you, and Franca was talking about midwives, ICM as a movement, and White Ribbon Alliance have been extremely successful in being a movement. So what do you see in reflection to what you've heard now in terms of who do we need to engage, who do we need to partner with, and what needs to happen?
It seems to me, I mean, this whole conversation concerns everybody, not just, those of us who are very active and here in the room, but, we're talking about the health and the future of society, of nations throughout the world. Everybody should be engaged in that discussion. What I see as an immediate next opportunity is really engaging strongly with the women's rights movement at large. This is a discussion that very much needs to happen there. The gender aspects, pay equity, this is not just a question for midwives, right? It's for women everywhere. The way midwives are treated within a very hierarchical and very misogynistic health system is also not just a question that midwives are facing, right? Women everywhere, from the film industry to everywhere are facing that. So we need to join forces with those larger movements and articulate the issues that midwives are facing within that, as well as the opportunity. I sat here reflecting on what it means for women to have opportunities for advancement, what it means for women to have opportunities for education and to advance as a researcher, as a professor. And this is what we value in society, whether it's right or wrong. This is how we value knowledge. This is how we value experience. We have certain ways to exhibit that. So it means a lot, especially for midwives coming from low and middle income countries, to have an opportunity to advance in their chosen profession. And midwifery is a profession that many choose because of personal conviction or personal experience. And they want to advance within that profession. They want to become better at it, and they want to learn more, and they want to be respected for what they're doing. So this is really important for them as women, not just as midwives.
And I think what you said there about this is for everyone, and it's not just for women, it's for men as well.
Yeah,
because
they're also born.
Yes, and I don't know if the young woman who was here in our conversation yesterday, she's not here now? No. I just need to share this, because she had a conversation with a politician here in the States, and an argument actually going on between them where he was saying, I don't think it's fair that I should pay taxes for maternal health interventions. How does that benefit me? And she said, I couldn't stop myself, but I just turned to him and I asked him, do you have a belly button? And he said, yes, I have. How so? Well, I think you have somehow benefited from maternal health interventions. And I think it was such a smart way to do this. So just to say that this is for all of us, right? Before we open up, any reflections from the three of you to anything else that the other panelists have said that you would like to, or you can come back.
If we have 10 years now, I can see that we have a large funding gap actually when it comes to implement these interventions we already know would have the positive impact. It's not rocket science.
No.
So funding for countries to develop feasible implementing strategies and allocate sufficient funding for that. It takes time to build capacity. Capacity development of human resources takes time. Our history is one example. So I think 10 years we could achieve a lot if we are just systematic and have clear action plans for it.
Thank you.
And of course we need to have governments supporting a comprehensive approach to sexual reproductive health and rights, including also safe abortion, access to family planning, which is important, essential components.
Yeah, I think joining the women's movement is something that certainly as ICM, it's one of our strategies for this year to try to point midwifery associations towards the women's movements in their countries and to really join women's movements. I don't quite know what went wrong with the feminist movement and the midwifery movement in the 60s and 70s, when somehow midwives were seen as people that wanted to keep women to have babies and stay at home or something like that. Because midwives are actually about sexual reproductive health and rights. They're not about making sure you have babies. They're about making sure that you keep healthy and the rights over your body. So I do think that joining hands with women's movements is very interesting, and I think it's a very strong way forward.
And I just want to say, we cannot wait 300 years. Women need help now. So, hopefully we take some lessons from other countries, but we need to really, we need to keep pushing, and we need to get it done. So,
Thank you. And I think that just from me, I think thank you for bringing the funding gap up, because what we have seen at UNFPA when we look at resource flows and when we looked at the commitments made in Nairobi, it was very surprising but very significant that the commitments to and the resource flows to maternal newborn health are going down. It's almost like, I don't know, donors and governments think that this is already something we've spoken about so long that it's a done deal. It's already happening, and we know that that is not true. Population is increasing. The numbers of preventable maternal deaths will prevail unless we put enough resources to it. So let's give the panel a hand up to. And now now we'll see how we can manage this with the right order, and don't feel really that we forgot you if you don't come exactly in the order that you saw you raised your hand, but we have a couple of hands, I think. So, and if we forget you, then raise your hand again. So
We'll take a couple of questions, and then
Yes.
the panelists can pick and choose.
I'm Laura McGue from URC, and I would just like to hear from the panelists about how they see the role of midwives with the nurturing care framework and how it fits in. Thanks.
Thank you very much. My name is Max. I'm from the Embassy of the Republic of Zambia. I'm an obstetrician. And I want to just, it's not really a question, but a comment that you said midwives are not the solution, but for most developing countries, they are. Midwives are the vanguard. If you talk about sexual reproductive health, child survival, maternal health, we've got a handful of obstetricians, and every obstetrician was trained by a midwife.
Here, here.
The logbooks we do when you have to train, it's a midwife who supervises you. They know it all. And they've got the numbers. So if we are going to look at women's health, for us, it's the midwives who the answer is. They are the system. And I think I would just like it to urge us that, yes, let's invest in one, leadership, and this leadership should be attuned to one, them as teachers, two, as practitioners, they have the art, and three, they must be at the strategic table so that they can influence the national agenda. I would summarize that way. Thank you so much.
Thank you.
I'm Christina Kramer from APT Associates. None of you mentioned traditional birth attendants, so I'd like to hear a little discussion about the relationship, the future of TBAs.
Shall we have one more?
Instead of just talking about advocacy, I would like to talk more about proactiveness. A year ago, I was at an event with the Secretary of Health of Bihar, and he's one of the most innovative secretaries of health in India. And he knew nothing. He had recognized that his biggest problem, one of his biggest problems, was maternal health, and not having sufficient professionals. I was the one that had to tell him about what was going on in Ahmedabad with the Swedish program, and describe to him what had gone on for years in Sri Lanka. I mean, you can choose champions. I mean, there's many states in India, but you can see who is actually interested in these problems and go and speak to them, as well as waiting for them to come to either the Swedish embassy or the American embassy or something like that and say, look, this is a problem you're going to have. Let's talk about a possible solution.
Thank you. So Anyone who would like to address the nurturing framework and the midwife's role in that?
All I can say is yes. I think what has often happened is that we've split women and babies. And I'm sure, Will, you can see this too, that somewhere we talk about care for babies and we talk about care for women, but the women and the babies are one. And I think that actually focusing on midwifery is the nurturing care framework. I do worry at times the kind of the accent on breastfeeding and supporting breastfeeding is not that, I don't think it's as strong as it could be in the nurturing care framework. It's again very important role for midwives, especially with NCDs. If we look at NCDs, connection NCDs and breastfeeding, it's very, very interesting. But babies and mothers, and I think if we care for both, when we care for the mother, we care for the baby. And I think midwives play an extremely essential role in this.
And then we had the gentleman from Zambia. I think there was a bit of a misunderstanding there. Did you say that we had said that midwives are not the solution?
Well, you did emphasize that they are
The solution. Yeah.
but working in a system.
Yeah.
And I was just trying to emphasize that they are much more powerful than that. They are the solution.
Yeah. And I think what was tried to say here was that let's not put all the burden on the midwife's shoulders. Let's have the enabling environments and the support to her so that she actually can deliver and not have to take on all the things that are faulty.
I think the gentleman is onto something. I think my most profound experience with how strong midwifery is was actually in Malawi, because there, they had a midwife in parliament, they had a midwife at the ministry, and in every healthcare facility. And like you said, they are the system, they're really running things. So when we look at examples, good examples of how midwifery is strong and can be supported, and midwives in leadership, etc., we need to look throughout the world because there are great examples in many, many countries. And in some ways, the fact that there aren't that many obstetricians, I think helps in a way, because they take on everything, and they're not, like we speak here in the States, allowed to. They have to do. And that is a very different way of viewing the world from a midwifery perspective. So I think there are great examples that can be shared from many other countries, and should be. I don't think any one country, as my colleague here rightly pointed, has it all figured out. So we need to take the examples where they're working and really show what that contributes to the health system, because it is critical to all of us.
Sorry.
I would like to add to what Franca just brought up about the woman and her baby, and taking this comprehensive approach to sexual reproductive health and rights also, I think it is important to engage men. And I sometimes I feel midwives tend to forget that, and I can see among my colleagues it's about the mother and the baby. And what distinguishes Sweden from other countries, I think, is the fact that we target also men. And it's men and women's sexual reproductive health. They have responsibility for contraceptive counseling, protecting from unplanned pregnancies as such. And I think, and starting from adolescence, we have today 200 youth clinics in Sweden. The first one opened 1970s. Although most of the clients are girls, but also boys. And they reach out in schools. So life skills and sexual reproductive health and rights, having the men together with the women is important, I think.
Then there was a comment about proactiveness and advocacy. I was thinking, anything that you would like to comment on that? I mean, it's true.
I mean, yes, absolutely true. And I think for India in particular, we are seeing change at the federal level as well. I think we need to. It's hard sometimes. Advocacy is hard. It's like banging your head on the wall. It is about how you touch that person's heart. Do you make them feel about something? Because so often we go with the data and the evidence and all of that. But what would convince a policymaker to change the way they're doing things is very, very different from person to person. So you have to keep trying. If somebody is already a supporter and advocate, that's great. But we need to also focus in places where they don't want to hear from us. So we need to keep going and trying different ways to encourage that. It does help to have women on our side, because what policymakers care about is what they hear from their constituencies. So if they hear it from women as well, that's also very, very helpful. So we have to be creative about strategies to get to policymakers and decision makers and involve them in a way that's meaningful. Like I said, not just a champion on paper, but really somebody who truly wants to move the needle. And they see a solution, because that's what we're providing. We're providing a solution to their problem. We're trying to help them and support them in what they really need to do.
Thank you. Yeah.
I do also want to address the question about traditional birth attendants. And I think Franca started doing this a little bit, but I think there's a great example from Mexico, for example, where traditional midwives provide 30% of the care in some regions of the country, especially indigenous communities, Afro-descendants, and in the mountainous and hard to reach areas. And they're great examples of how education can be enhanced in a mutually respectful and culturally appropriate way, so that everybody coming to the table has something to offer, and everybody coming to the table has something to learn. So it's not one-sided only. And I think it's a great example, and I look forward to seeing more examples like that from other countries.
Thank you.
I really love that question about the traditional birth attendants. I think it's so extremely relevant. We really need to look at that, and as midwives, we need to walk the talk. Because as midwives too, for a long time, we've kind of been pushed to the side, and we need to stand for ourselves and also stand for the traditional birth attendants. We are a team, and I think everyone has their role to play. Mexico is a very interesting example. They actually have an association of partera tradicionales and partera profesionales together. One association for traditional and professional midwives. And I think that we need to know what each other's roles are. I think often traditional birth attendants have a clear position to support women to get to a midwife, to translate what the woman needs, and we need to work with traditional birth attendants. As ICM, we have a position statement on traditional birth attendants. They are our colleagues.
Yeah. Very good. Thank you. Let's have some more questions.
Yes, I had a question to Franca, actually. So universal health... Oh, sorry, my name is Will Zek. I'm from UNICEF. I did 10 years of OBGYN before joining the United Nations. So universal health care is gaining so much momentum, and it's great. At the same time, there's a second stream, primary health care. It's almost gained the same momentum within UN member states. How do you see that connection, between... How can midwives help to be a pillar in the community? Do you see that they need additional skills, maybe additional tasks they have to take on? And the second question, from my own experience working in low-income countries, stigmatization in the community level. Sometimes you have a healthcare center, there's only one midwife, and then you have a young girl being pregnant, and sometimes, it's the neighbor, the midwife is the neighbor, or she's part of the community, and then, there's rumors, there's a bit of, she's pregnant, she's the neighbor, she's the daughter of this and this person. How can we improve the quality? Do we need additional skills for community midwives in that sense, but also in terms of SRHR and other areas?
Well, I think the first one about primary... Sorry. Yeah, quite
Yeah.
right. Yeah. Thank you.
Hi, Jill Gay, What Works Association. My question is around Mexico also, and it's where I worked for the MacArthur Foundation, promoting midwives. But there's a real struggle between the midwives and the physicians. And the physicians have a lot to lose in terms of money, position. And I guess my question is, what are effective ways to address the very real threats that the physicians feel, and yet we know that the care is more cost effective and better when provided by midwives. But the doctors have the vested interests in keeping the power.
Thank you so much, Geeta Lal, UNFPA. My question is about, yesterday we discussed a little bit about the engendering of the midwifery workforce. And I think Sarah mentioned in the beginning that about 70% of the midwifery workforce are female. We are seeing a rising trend about men joining the midwifery workforce in several African countries like Ethiopia and Uganda and other countries. I mean, so do you, does the panel see a shift in change, a shift in perceptions? And do you think this trend, if it was to gain speed, and if we were to promote this trend, would this have a positive impact on your pay scales, the whole enabling environment? So what is your perception about that?
Two more?
Yeah, we can keep.
Hi, Annette Scarpita, Mavuno, and two other grassroots organizations in DRC. I want to drill down to the local level. I have an example. I've worked with a community for close to 10 years. If they have a midwife, I don't know about her. She would be unskilled. There is a nurse in a clinic that is almost empty with shelves and supplies. The nurse is not paid. There is a woman originally from this village who is now in nursing school. So also the women of the village have advocated, taken a letter to the health department locally. But, and Franca, this part is for you, and others, I'm sure. All the countries have signed on to support universal health. What about if it's a country that is divided east and west? West is where the power is, and east, there's really no infrastructure at all.
Okay, one more.
Hi, I'm Peter Johnson. I serve as a Senior Director for Nursing and Midwifery at JPIGO, an international NGO. Franca, I was really impressed by your remark about the patriarchal roots of bundling nursing and midwifery. But we know that that is common in countries at both a governance and a regulatory level. And I'm wondering what your thoughts are on when that's okay, when that's not okay. I know there's economic arguments for regulating nurses and midwives together, but I've seen chief nursing and midwifery officers in countries be very effective advocates for midwifery. I've also seen them very isolated and divorced from midwifery and maybe not a midwife at all. So I just like the panel's thoughts on that.
Okay, so here we go. We have a lot of questions. So we had the first one really talking about the relationship between PHC and UHC. That came from Will. And are there different skills that the midwife needs to attain to be able to work at that level? And how do you overcome stigma?
Well, midwifery is primary health care. That is midwifery. So it's obviously, and I think we can only attain UHC through primary health care, through prevention. So I think midwifery is that. The thing about the stigma, midwives really need to look at themselves, and I think we do at times are moralistic or judgmental. And I think in certain countries, women or adolescents do find it hard to go to the midwife because they worry. And often it's the group that are most at risk. So young women, and the chance of a young woman, if she's pregnant, to die of unsafe abortion is really high. And as midwives, we need to look at ourselves, and I think as ICM, we need to give the example to our midwives that we have to give this care. And we have to be open, but of course, midwives are human beings. But I can see the issue, and we need to look at ourselves and be critical. And we need our obstetrician colleagues and our other colleagues to point it out to us so that we can learn.
But maybe a short follow-up to that. I think what is also, and I totally agree with you, midwifery is primary health care. At the same time, we know the scarcity of numbers of midwives, and really the need for them to also be at least at the first referral level, to be able to handle all the complications. So is there a way where midwives can then task share with other cadres and be the lead of other cadres, or
I
how
think
do
we
you
can, and at times we have to be realistic. You know, in certain countries, midwifery or people are not midwives according to the international definition. Maybe we have lots of issues with that, and I think we have to be realistic. And I think we can task share, but what we must be careful of is that we do a kind of like a temporary measure to try to get care that's not really the best care that women deserve, and in the end confuse the whole system with having so many different cadres. So if you do a temporary measure, make sure it's temporary, and make sure that in the end you do get those midwives at that top level working within that enabling environment. That's the only issue that I worry about.
Then we have the one question on struggle between midwives and physicians and taking away power. Elena, power.
Very familiar with the Mexico context and the struggles there, but this is in no way unique. I mean, this is the same struggle we have here in the United States. It's the same struggle that's happening in parts of Eastern Europe, where I'm from, and maybe in the rest of Europe as well. So this is not, I mean, India, there's so many countries where this is a concern. I think, from my perspective, nobody goes into this profession because they want to get rich. I think this is not the way to go. Will talks very well about the risk, the immense pressure that all kinds of professionals that assist in childbirth feel, and especially with the threat of litigation. And for me, I think what we need to keep reminding people is why they went into the profession in the first place. Why are they doing what they're doing? It's very at times dehumanizing when you have a huge caseload and you have so many women, and you're maybe, as an obstetrician, you're doing C-sections all day long, every single day. And you stop feeling, and it's really hard to get back to the why you started doing this, and why you're doing it. I think it's important to point how much better the system will work if midwives are part of the system. If you work in a team, how it relieves your pressures as well. If you trust, your team members, how that improves your environment. If there is respect and dignity in the delivery room, it's not just for the woman; it's for every member of the staff, right? The way people interact, team members interact in healthcare settings, it impacts all of them. Whether you feel stressed or relaxed, so it improves your working environment as well. And these are some of the things that we need to keep saying and we need to keep showing. And in Mexico, there are teams that are working very well, and there are facilities that are working very well together, and they trust each other. And these are the examples that we need to keep showing. And it'll take time. I think that's the reality. But knowing that you're not unique in that situation, that you're not the only country or the only healthcare system facing that tension, I think it's really important.
Anyone else wants to add to that?
Well, I do think the issue of healthcare is a commodity. If healthcare is a commodity, then you try to get money out of healthcare. And I do think that the system whereby you get paid per intervention creates that people want to do interventions. And midwifery, we need to see that the intervention of being able to wait is also an intervention. The intervention of giving deep time and trust should be seen as an intervention, but it's not actually an intervention that's paid for. So we need to also support obstetricians and midwives and nurses and healthcare professionals in that way, that you're not paid by intervention.
If I may, as moderator, add one thing. I think it's really difficult to be moderator when you... I'm burning with answering all it, commenting on all these questions. I do think that one problem is that many health systems have been set up with a very heavy bias to making the foundation basically doctor-based. Yes. So you've educated enormous amounts of doctors instead of nurses and midwives. And of course, there is a tension there. They have been educated for that job. So we need to prove the cost effectiveness of having another type of system and not making it just into a battle between the different cadres, I think. Let's move to another question. The next one was from DRC, and I think talking about a failing health system and how can we, as agents of change in different ways, help with countries that there's big inequities between different parts of the country, and can we do something about that, and how can we work?
As global actors, what we could do for low resource settings, was that the question?
Or maybe I think the question is, when there is big inequities, how can we as, interveners or supporters to that government, how can we make sure that it's not only one part of the country? And we see this a lot in middle-income countries, I think, where the pockets of poor people are now seeing the lack of
United
quality.
States of America.
Yes, yes.
Well, I think so. The Swedish government is we have a feminist foreign politics. We have clear goals as to close gender gaps and more specifically girls' and women's rights, to protect them. And sexual reproductive health and rights is one of these goals. So as a government, from ministers and all down, they have internalized this gender equity. And we also have this authority now in Sweden for promoting gender equity in all governmental institutions. So Sweden are pushing and mobilizing other governments as to be aware and push for this. And of course, this is also, it's not a quick fix, but another thing Sweden is doing is also to allocate resources to build capacity in low resource settings where you promote midwifery through UNFPA, for example. But I think these capacity building programs need to be context sensitive. That's one important aspect, I think. There is no global solution to this. Quality of care indicators and to bring in relevant indicators for each context is also important, not looking at how many women died and children died. So quality improvement processes in facilities, I think, could also have promote this interprofessional collaboration between physicians and midwives, and to show for healthcare managers as well as the Minister of Health that this is the cost-effective solution for you. These are the tasks for midwives and these are for physicians.
And maybe, if I may, these are more and more countries are fragile, as we call them. They are moving between sort of being a humanitarian country and a development country, and where we see health systems and other systems failing. So I think what one important piece here is to also have the humanitarian interventions be more also development focused, so that we don't just go in with, the clear humanitarian support, but we also build preparedness and resilience. That's my take on that. Regulations, nurses, midwives, Franca, maybe together or separate, or what is the best?
I think it depends on the country. As long as we do no harm to either of the other profession. I think if the professions can very much support each other, we must make sure that the power games don't mean that one or the other doesn't come to its biggest potential. That's what we need to look at. And I don't think you can say it must be separate. We do see that there where it's separate, midwives tend to come to the potential better. But it's a long road.
Yeah. Yes. I also,
There's
go ahead.
one question about the male midwives that I wanted to address.
Yeah, sure.
So it's fascinating to me, especially from a human rights perspective. I think, in general, I love when we see here in the United States, let's see, male midwives, male nurses, male kindergarten teachers, anyone who is challenging what is essentially a gender norm, that, women are better at this and men are better at this. I find it fascinating to hear, though, when we have male midwives in large numbers, like in Ethiopia, somewhat in Malawi and other countries, how women's perception change. And I think we need to unpack that. So, for example, we've heard that women regard male midwives as being more respectful. Now, whether this is true or not, that merits some examination. But it's fascinating. Does it have to do with the fact that that person is male? We've also heard that, more often than not, then women will think this is a doctor because it is a male. And a female doctor standing next to him might be then considered to be the nurse or the midwife. So the gender dynamics there are just fascinating. Now, whether this will lead to an effect on the pay scale, on a positive effect of sorts, I don't know. And to me, that would be too sad if this is what it takes to lead to improvement. But I think any changes like that, they need to be examined critically, from a gender lens, and really see what is happening in the health care system and how does that affect the care for women.
Thank
Can
you.
I add one small thing to that, Annika?
Yes, please.
One thing we do see as ICM, and that we do also worry about, is that when you see in those countries where there are many men in midwifery, there is a very inequitable number of men in the top of midwifery. So when a woman is in a man's job, she has a difficulty getting through to the top. When a man is in a woman's job, he does not have difficulty getting to the top. And I do worry, and we need to, of course, stand with each other as partners, but do realize this, because you see that. Look, for example, at the Ethiopian Midwifery Association. It's run mainly by men.
Thank you. And time runs quickly when you have fun, as they say. So we're almost there. But we have one question from Twitter, and it's Darcy Allen from Women Deliver, who asks, for Beijing Plus 25, the global action coalitions that will happen in Mexico, we hope, and in Paris in the summer, how do you hope to see midwifery incorporated in gender equality discussions and commitments? Anyone?
We see them being integrated.
Yeah.
Yeah.
So we're starting next week with a campaign on Twitter asking women to define what their equality declaration would say. And we wrote our own. And in it, we want a clear articulation that childbirth and rights in childbirth are part of sexual and reproductive health and rights. They were not explicitly called out in the Beijing Declaration and Platform for Action, so I think that needs to be there. And that midwifery is an integral part of that. So we want to hear from all of you how you would define, if you were writing your own equality declaration, what does equality mean to you? And to start engaging with us on Twitter starting on Monday, because we can't wait for Mexico. And we need to also organize online, just in case. So the hashtag is #MyEqualityDeclaration, and please send us your own and raise your voices on midwifery.
Great.
Thank you. And by that, I would really like to thank the three of you for such rich discussions, comments. And for all of you who have been so engaged, and I think we've had a brilliant discussion that I hope will continue as you leave, but as also we go out into our own organizations and where we are at to bring this forward, because I do think that we need to partner broadly. Thank you all.
Thank you,
Annika.
Thank you.